My presentation was about solitary plasmacytoma. So solitary plasmacytoma is a rare condition that is characterized by a solitary mass of clonal plasma cells, and you need to exclude the presence of multiple myeloma. So it is defined by a minimum or no bone marrow involvement, and the symptoms must to be only related to the mass, the solitary mass. So there are two different entities, so solitary bone plasmacytoma that represents 70% of all the solitary plasmacytoma cases that appears in red marrow bone, so preferably in the axial skeleton, femur, pelvis, or ribs. And then there is the extramedullary plasmacytoma that is represents 30% of all the solitary plasmacytoma cases and can be anywhere, but is most typically localized in head and neck region, gastrointestinal tract, or lungs. So these are the preferred sites. So there are several things that we need to take into account. So first, when we do the diagnostic workup of these patients, so we need to do free light chain evaluation apart from the standard protein analysis, because free light chains do have a prognostic impact. So if we have abnormal free light chain at baseline, those patients progress more frequently to myeloma. Then we need to do imaging, but because we need first to be sure that there is only one lesion, so it's only a solitary plasmacytoma. And then also it is important to have to gather also prognostic information. So the two most reliable techniques would be MRI or PET-CT scan. Probably MRI is preferred for solitary bone plasmacytoma, and PET-CT may be preferred for extramedullary plasmacytoma, okay? But in both cases, if you have other lesions outside the principal one, so foci of replenishment of the marrow in the MRI or hypermetabolic lesions in the PET-CT, those patients also have a shorter time to progression to multiple myeloma. Then we need to do bone marrow evaluation. So first, to rule out myeloma. So we need to have less than 10% clonal plasma cells in the bone marrow, and then also to evaluate minimal marrow involvement, because that is also of prognostic importance, and patients that have bone marrow involvement with solitary bone plasmacytoma, extramedullary plasmacytoma is not impact of that, also have a shorter time to progression to multiple myeloma. So treatment has not changed in the last year, so involved field radiotherapy remains the standard of treatment, and with that we achieve a control rate of 80–90% with very low relapse rate of around 12%. So surgery may be only used in case of core compression or to stabilize some fractures. And then we have also the role of chemotherapy that still remains controversial. So chemotherapy should not be recommended because we don't have prospective data, but may be interesting in patients with large bulky masses, in patients that the disease doesn't respond to radiotherapy, and also for those patients that relapse after treatment. But still, no prospective data is available.